Hi guys, I'm Sajjad Pathan and this is a video series for high yield concepts which can be tested in your SAQ exams. So I want you guys to be thorough with these concepts before you go for the exam. We are going to deal with multiple pictures and identifying them as soon as possible as we see it. Let's begin it. I want you guys to stay awake. I want you guys to understand that this is something which is very essential, and more than about, I would say, 30 to 40% of questions can be framed from these concepts. So wake up, and this lecture will help you pass the exam very, very easily. So a disclaimer are these are just my views that this can potentially come in the exam. The images which I have taken are from Google, so they may be subject to copyright. And when you're these concepts, please use it at your exam. Use it with your clinical acumen for your patient care, because you might have to improvise on what you learned today. Okay, and nothing in this life comes easy, guys. Nothing in this life will come easy. You need to work hard to get what you want. Yeah. So the picture which you see on the other side is not a hypoglycemic collapsed guy. It's me, who, when I was studying for these exams, I used to sleep in the library after the shift. I don't want to waste much time on that, but I just wanted to emphasize on the aspect that you need to work hard if you want to see yourself successful. What are the hints to pass? A simple hint is, you use the college curriculum to prepare for your exams. Keep your copy of your curriculum with you. The college gives you the curriculum and they say, okay, this will be tested. And they even say it clearly that you need to have the knowledge of this, you don't need to have the knowledge of that. So keep the college curriculum. Practice on RChem learning. RChem learning questions are very good, and college has given it to most trainees who have subscribed for it. Practice RChem learning. Potentially, I think it's my understanding that majority of your exam questions are framed by the same authors who are contributing to RChem learning, because I've seen similar patterns appearing on RChem learning, same images appearing in the exam. And prepare well, look at the pictures, study in groups. If you make groups, small groups, and discuss and make your own SAQs from a topic which you read, you will start understanding how an examiner is thinking, what has to be tested. Rather than just trying to memorize, you read a topic in a group, make one short answer question, give it to your colleagues, let them answer it, ask them to make one question. In that way, you will understand what are the points I have to know for this exam in the book. Rest well before the day of exam. Have proper sleep, 8 to 10 hours of good sleep. Reach the exam center early. So for those people, especially the international students who are doing in India, Oman, Singapore or Malaysia, you guys book a hotel near your exam center. Go there a day in advance. In the evening, walk to the exam center and see how much time it takes. What it will be like if it's a traffic situation. If you have taken a hotel far away, then you might not know what traffic situation would be, because the timing of the exams are same all over the world. It starts at 10 o'clock in the UK, it starts at 1:30 in India, and similarly it will be in Oman. So it usually happens at the same time. So plan your journey ahead of time in advance. So I would recommend going to the center a day before and staying very close to the center so that you can walk. It will take 10 minutes to reach, 15 minutes to reach. You will have an understanding, and you will not be having the anxiety about an unknown place. Carry your ID. Don't forget to carry your ID, and loads of sharpened pencils. Take 10, 12 of sharpened pencils. Center provides you one or two with pencil, eraser, but it's always better. You don't want to waste your time sharpening pencils. Take your own. Take 10, 15. When I did my FRCEM finals, I did that. I carried 15, 20 sharpened pencils. Finished, aside. Finished, kept aside. So I don't have to waste time on sharpening. Read the questions well. The questions will have some specific words. So you need to know what the examiner is asking. If they say, what are you going to do about the patient's management, you need to answer the management question. If they ask, what is the pathophysiology of the condition, you need to answer the pathophysiology. So read the questions well. Plan your exam in 6 parts. This exam is very lengthy. This exam will be like a 3-hour exam. 3 minutes for each question. That means for 1 mark, 1 minute. That means normally you will say, okay, I need to do 20 questions in an hour. I would break it down further. I would say 10 questions in 30 minutes. However, if you keep a target of 10, you may complete 9. So keep a target of 11 to 12 questions per 30 minutes and then reassess yourself every 30 minutes. Okay, I have done this, next 30 minutes, and forget about the things which you have done. Think about just the next 30 minutes. Another 11, 12 questions. In that way, you will be able to. Don't waste your time thinking about any question. If you don't know the answer, you likely don't know it. Keep it aside, don't waste your time. When they ask you calculations of any formula, write down the formula. Formula fetches you half a mark. So write down the formula. Don't mess around with the calculations. Leave it for the end. If you have time, come back and do it. Because 8 out of 10 times you will be having the answer wrong at the end. Because medical doctors are poor in mathematics. Skip the questions if it's taking too long and think about common things. If the best way is, think that you're in the ED and this patient is in front of you and then answer those questions. What is the most likely diagnosis? What are your differentials? You will make it easier rather than thinking it separately that this is an exam. Think the patient is in front of you who's come. I'll give you a simple example. Patient is come with chest pain. It says radiating to the back, tearing type of pain. When you're writing in the exam, you may think ACS, 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 and then you will be blocked. Here, if you think the patient is in front of you, first thought which comes is dissection. Okay? So this way, write legibly, clean and neat. Doctors have poor handwriting. That's why practice writing with pencil. Write legibly. Don't sit and write illegibly, because if I don't understand what you have written, I can't give you marks. Write the correct answers first. Write the best thing which you feel as first. So in the example I gave you, I said aortic dissection. That should be the first differential, not the last one. GERD should not be the first one. GERD should be the last one. Okay? Write small, short bullets. You don't have to write essays. Otherwise, you will not be able to. Do not leave anything blank. What I mean is, write something. And I told you in the previous thing, we know our common friends. Lymphoma, leukemia, magnesium, cocaine, ACE inhibitor. Write something. Don't leave anything blank. Don't look at your neighbors. Concentrate on your work. Your work is important if you do well. Don't think about you have to remember the questions so that you can help somebody else. No. First of all, it's illegal to share the questions. So you don't have to think about, okay, and attempt all the questions, as I said. If you plan well, 11 to 12 questions in 30 minutes and reassess, you will be able to attempt. First concept we are going to learn here is waveform capnography. You need to know that this is a square box. This upstroke is expiration and this downstroke is inspiration, and this is the letter. Okay? Expiration, inspiration. What is the normal EtCO2?
4.5 to 6.
So normal EtCO2 is just similar to your PaCO2, 4.5 to 6. So anything above 4 is good. It measures the end tidal CO2. It is used for confirming and continuously monitoring ET tube placement. What are the common causes of desaturation in an intubated patient?
Dope.
DOE. We all know DOE. Displacement, obstruction, pneumothorax, or equipment failure. Good. Yeah. It is being measured to monitor the quality of chest compressions in CPR. And it is also useful for early identification of ROSC. Yeah. Use it in every procedural sedation to monitor patient's respiratory effort. So there is a topic in practical procedure called as monitoring respiration. How do you monitor respiration?
Saturation, EtCO2, respiratory.
Inspection, percussion, palpation, auscultation, then your saturation, respiratory rate, EtCO2. Yeah. So these are the things you need to monitor. Waveform capnography changes when the patient situation changes. Now this was a nice square, and suddenly I see a straight line. What has happened? One of the DOE. Displacement, obstruction, pneumothorax, equipment failure, disconnection of the tube. Patient is not breathing. This is usually seen when you have given some sedation and then suddenly patient doesn't breathe. The second one is the CPR assessment. If you see, it gradually increases when the quality of compression increases and you want to keep it about 20 or 2. CPR was going on and suddenly you get a ROSC. This is something which can come up in the exam. It looks like a shark fin. So when I said the expiratory phase was kind of slow and gradual, looks like a shark fin. Whenever you see a shark fin, it is bronchospasm. By convention, either it's asthma or COPD. This is a guy who is breathing slowly, gradually. There's a long plateau. That's hypoventilation. The guy who's breathing fast is hyperventilation. And I think that is it. Resuscitation. Whenever you're doing your resuscitation, you should remember your 4 H's and 4 T's. Okay. After you get a ROSC, we used to call it hypothermia. Now we call it as targeted temperature management to 36 degrees. Yeah. Fine VF. Whenever VF is fine, treat it as asystole with good quality chest compressions. If the VF is fine, what you can do is you can adjust the gain to see actually it's a VF or not. However, when you don't have time to do all that, good quality chest compression is what will the patient benefit from. Yeah. Adrenaline, at or just after the third shock, 1 milligram, 1:10,000 IV. Amiodarone, 300 milligrams after the third shock IV. Okay. Amiodarone also comes after 5th shock, that is 150 milligrams. Okay. Opium toxicity, anybody who's come with pinpoint pupils, suspected drug use, low respiration, you want to give naloxone, 400 micrograms. You can repeat the dose, up to 5 doses. Yes, you can repeat it every 2 minutes. 400, 800 if you're giving IM, 2 milligrams if you're giving intranasal. Okay. So, and then once the patient responds, you need to start an infusion. In TCA, think about sodium bicarbonate. Sodium bicarbonate, 50 mils of 8.4% sodium bicarbonate. It's not soda bicarb. It is sodium bicarbonate. Okay. When do we give it? TC overdose with arrhythmia, hypotension not responding to fluids, QRS which is widened, and resistant acidosis. Cocaine, first line benzos. Yes, first line benzos. If the blood pressure is high, despite giving benzos, you can use nitrates. What drug which you will not use is beta blockers. No beta blockers. You give calcium channel blocker or phentolamine. Okay, cocaine, phentolamine. Hyperkalemia. We are classifying hyperkalemia as mild, moderate, severe. Mild is 5.5 to 6, then 6 to 7, 7 and above. Mild, moderate, severe. First thing we see is a tall T waves. Tall T wave, then gradually it can change to short QT, long PR, wide QRS, and sinusoidal. Tall T waves, short QT, then wide PR, wide QRS. Most common cause of high potassium. Consider you have done a venous blood gas on a patient. You ran the venous blood gas and potassium came 8.
Spurious.
Tourniquet.
So most common cause is hemolysis.
Yes.
So if they say you saw a potassium of 8 on the blood gas, what would you do next?
Repeat.
Repeated.
Repeat. What people write in their exam is insulin, glucose, ECG. And then they say, I wrote the right answer. You're wrong. What do you do in your practice? You
Repeat.
correlate it. Oh, the tourniquet, maybe hemolysis, I'm going to repeat it. And in the meantime, ECG will be done. If still it's high, then I'm going to start the treatment. Yeah, if it is an obvious CKD patient, if the scenario changes, a dialysis patient missed his dialysis, came in, you did a blood gas, potassium is 8.
Insulin only.
Here, you will say
Correct. Potassium.
ECG and correct the potassium with giving
Insulin dextrose.
calcium gluconate, insulin dextrose,
Nebulization.
salbutamol, sodium bicarbonate if it's still raised in. If it's still raised in,
Dialysis.
dialysis. What are the indications of dialysis is the question.
As, non persistent hyperkalemia with acidosis, hemodialysis.
No, there's a mnemonic. He taught me mnemonic.
Do you guys know what are the vowels?
AEIO. Yeah. Acidosis.
A-E-I-O-U. Yeah?
Yeah.
Resistant acidosis,
Yeah.
resistant electrolyte imbalance, hyperkalemia or hypermagnesemia or hypercalcemia, ingestions like
Toxins.
dialysis ingestions,
Overload state.
fluid overload state due to CKD, uremia, uremic pericarditis, uremic encephalopathy. Yeah. What are the causes? We discussed about hyperkalemia is hemolysis. Second is
Renal failure.
renal failure. Okay. A patient is lying in the cold winter. What is the cause?
Rhabdo.
Rhabdo. Yes. Elderly man fell at home. Carers turned up, didn't open the door, broke the window, called the police.
Burns.
Then he is found fallen down, fractured neck of femur, suspected. God knows for how long they were on the floor. You suspect rhabdomyolysis. Drugs. Beta blockers, ACE inhibitors, spironolactone, yes. Digoxin. First thing what you'll do is stop offending agent if they are on the drugs. Calcium, insulin dextrose, salbutamol, sodium bicarbonate, potassium exchange resin, and renal replacement therapy. So We saw hyper, we'll see hypo. Anything less than 3.5 is mild. Anything more than less than 2.5 is severe. So causes, most common
Of hypo.
of hypo.
Diarrhea, vomiting.
Most common causes, diuretics. Yes. Diarrhea, vomiting is there. Dialysis can cause. Renal tubular acidosis can cause. Or Cushing's. Yes. First thing what you do is you do an ECG. ECG will show U waves or flat T. Yeah. Give potassium. If they can take oral, give oral. If they can't, give IV. Slow correction. Yes. If it's a cardiac arrest scenario, you're going to give 2 millimoles per minute over 10 minutes. 2 millimoles per minute over 10 minutes. And then 1 millimole for the next 10 minutes. So 2 millimoles per minute, that's 20 millimoles. Then 10 millimoles. So in 20 minutes of CPR,
30
you're going to use 30. Also, whenever there is a hypokalemia, especially when it is severe, there will be a associated hypomagnesemia. So you're correcting potassium, but it's not getting corrected. Think of magnesium. Think of magnesium. Hypomagnesemia in itself can be a cause of hypokalemia and hypocalcemia. Yeah. All alcoholics are deficient in magnesium. So giving them magnesium helps. Magnesium was one of our friends. It is used for torsades, eclampsia, asthma, AFV for rate control, along with beta calcium or digoxin. It is used in resistant VFVT. If you see the ALS algorithm, after the fifth shock comes amiodarone 150 and magnesium. Migraines. Alkalosis in general is associated with hypokalemia. Alkalosis is hypokalemia. Acidosis is hyperkalemia, except for renal tubular acidosis, which is vice versa. Renal tubular acidosis is hypokalemia, otherwise alkalosis. There are two causes of normal anion gap metabolic acidosis. You guys know raised anion gap metabolic acidosis, you will say mud piles. But when I ask you what is a normal anion gap metabolic acidosis,
Acetazolamide.
yeah, it can cause. So renal tubular acidosis and diarrhea, and then acetazolamide is another drug. One thing here to learn is this is very important. Hypothermia. Yesterday we talked about hypothermia a bit. You need to confirm for signs of life in a cardiac arrest situation for 1 minute, especially if it is severe hypothermia. Hypothermia is classified as mild, moderate, severe. Mild is 32 to 35. Moderate is 30 to 32. Severe is less than 30. However, for ALS, 30 to 35 and above 35, you need to think of the different changes or recommendations in CPR. But classification is this: mild 35 to 32, moderate 32 to 30. Some book even says 32 to 28, and severe is less than 30 or less than 28. Yeah. Whenever you're feeling cold or whenever you're cold, what happens? You shiver. Yeah. At what temperature shivering stops?
Starts or
Stops.
32.
32. Shivering stops at 32. Yeah. Confirm for signs of life for 1 minute. If there is a ventricular tachycardia or ventricular fibrillation without a pulse, 3 stacked shocks, then just chest compressions until the temperature goes above 30. Yeah. No drugs until temperature is less than 30. Once it is between 30 to 35, you double the duration. So normally we are giving at alternate cycles, 3 to 5 minutes. Here we'll make it 6 to 10 minutes. So every 4th cycle. Active and passive rewarming. This we tend to forget. In real life we do it. In the exam we tend to forget. Yeah. J waves. If you see this, looks like an RBBB. This one. Yeah, looks like an RBBB. Looks like an RBBB. However, in RBBB, this R is taller than this one.
RSR.
So, this is J waves. J waves. You can see J waves in hypothermic patient, but it's not pathognomic. It can appear in other conditions as well. Other conditions, it can be a normal variant for a person. Hyperkalemia can give rise to it. In brain injuries and in ventricular fibrillation, you can see it. Hyperthermia. Difference between heat exhaustion and heat stroke. Main thing is this: no sweating, excessive sweating. Okay. Remember that what can cause hyperthermia differentiates: cocaine, ecstasy, amphetamine. Okay. Mostly these are drugs. Okay. Neuroleptic malignant syndrome. These are your antipsychotics. So antidopaminergics. Serotonin syndrome. These are your SSRI. And malignant hypothermia. This is your inhaled anesthetic agent, succinylcholine.
Succinylcholine.
Huh?
Succinylcholine.
Yeah, succinylcholine and inhaled anesthetic agent. These two. Malignant hypothermia. How do you differentiate between these three? Clinically. See, all of it will come with temperature more than 40.
Rigidity?
All of it will come with, may come with high blood pressure, 180, 200. All of it can come with tachycardia. Now, how will we clinically differentiate?
In NMS there have rigidities?
So, neuroleptic malignant syndrome is antidopaminergic, so they will have rigidity. Yeah. Whereas in serotonin syndrome, they will have carcinoid, produces serotonin. What do they come with? Flushing followed by diarrhea.
Diarrhea.
Yeah.
Flushing followed by diarrhea.
Yeah.
Yeah.
Normally we have diarrhea, then we flush. But here, flushing followed by diarrhea. So serotonin can come with diarrhea and flushing, right? Then the main point is myoclonus and hyperreflexia. Serotonin syndrome will be having a hyperreflexia and or myoclonus. NMS will have rigidity. I said NMS because of antipsychotics, right? Antidopaminergic. Can it come with something else?
Prolactinemia.
Any antidopaminergic.
I think theoretically yes, with prolactinemia it can. However, where I was going was, what did I say? Out of 400 patients you see at our ED, how many of them are elderly?
Yeah, half of them.
200 plus. How many of them are on having Parkinson's? Now, they are living alone. They become ill at home. They could not get in touch with anyone. They don't need carers, so they were independent. And now because they had been having fever or some reason or the other, they haven't taken their Parkinson medication.
Cogwheel rigidity.
So now they can come with, they can come with this one, NMS, right? Because antidopamine. So they will have rigidity, they will have high temperature, and then you will treat sepsis, rather than giving them their
Parkinson medication.
So that thing you need to remember. Serotonin we talked about, it's due to SSRI or SSRI plus SNRI or SSRI plus SNRI or SSNRI or SSRI with TCA, or there are 3 other drugs which we need to know.
Treatment?
No.
Serotonin.
What can precipitate? A patient is on SSRI. And now you have started in your department with another medication, and then he gets serotonin syndrome.
A simple tramadol.
Yes. So remember, there are not a lot of medication. There are just 3. LOT, lot. Linezolid, ondansetron, tramadol. So now consider there is a patient who's on antidepressant. He's coming because he was having sepsis. He was complaining of pain and vomiting. So you gave him tramadol plus ondansetron, and then 2 hours later his temperature is 41, his blood pressure is 200, heart rate is going above the roof, temperature is not coming down despite you give paracetamol, and you think severe sepsis, because urine output is gone because of rhabdomyolysis, and then you say, oh my god, what's happening, I don't know. You have done active passive cooling, still it's not coming down. Broaden your horizon of thinking that along with septicemia, it is you who have caused it by giving your tramadol and ondansetron. I can frame this same scenario in a different way. Patient is come, he is on SSRI, and you see that his culture from an abscess which was drained showed MRSA. You prescribed linezolid. So broaden your horizon, use your knowledge which you learned in your FRCEM primary about the drugs and drug interaction. I can frame that question as a drug interaction question. Like I said yesterday, patient is taking lithium and then came with pulmonary edema, you gave him furosemide. You started a diuretic, drug interaction, precipitated lithium toxicity. Magnesium hypothermia is a complication of succinylcholine or succinylcholine or inhaled anesthetic agent. Temperature will be high. The treatment for these 3 are different. Active passive cooling is there. Dantrolene is used in all 3.
Bromocriptine.
Dantrolene is used in all 3 for temperature control after discussing with National Poison Information Services. However, this is due to lack of dopamine, so you need to use a dopamine analog, which is your bromocriptine. This is due to excess serotonin, so you have to use anti-serotonin, that is cyproheptadine. Giving these 2 drugs, you should speak to NPIS again. So that was it. Rigidity dyskinesia, hyperreflexia, myoclonus diarrhea. I told you about linezolid, ondansetron, tramadol. These are the main ones. And treatment is supportive cyproheptadine, supportive bromocriptine. Dantrolene is only used for temperature. How do you manage temperature? With passive active cooling, benzodiazepine, dantrolene, there is no role of paracetamol.
Because this is hypothermia. It is not pyrexia.
So we'll go to succinylcholine. Succinylcholine is a depolarizing nerve muscle blocker. Normal dose is 1 to 2.5 milligram per kg when you're doing your RSI. What do I mean by depolarizing nerve muscle blocker?
The vesicles which are in the synaptic cleft is
So imagine succinylcholine is like your acetylcholine. It is succinylcholine, but it's not. So it's like normally I will come and teach you guys, so you will contract normally. However, instead of me, my clone has come and he's coming and he started teaching you. So you will still contract, and then my job is to make you contract so much that all your area is occupied by me. Now, no more contraction because I'm not allowing anybody else to come and sit over there. So succinylcholine goes and sits on the receptor, starts the contraction, and then all the receptors are blocked. Done. After that, no more contraction, no acetylcholine coming and sitting anywhere. So it's depolarizing first. That's why it causes transient hyperkalemia, because sudden contraction happens. Immediately when you give it, you see fasciculations. That raises your potassium. It can cause bradycardia, it can cause histamine release, and may precipitate anaphylaxis. Then one thing we learned was malignant hyperthermia. It's a very short acting, so the recovery is like within 10 minutes. Succinylcholine goes, sits on the receptor, occupies it, paralyzes, then it is broken down by pseudocholinesterase into sucs separate, choline goes back and forms acetylcholine. So malignant hyperthermia is hypertension, tachycardia, pyrexia, treat with dantrolene, succinylcholine apnea. This is a complication. You've given succinylcholine and you've intubated the patient. 10 minutes have gone. The patient is still paralyzed. You think I'm going to put him on spontaneous breathing, but you can't. Or you're in the theatre, you have paralyzed the patient for a surgery. Post surgery, you want the patient to be fine. Despite you given neostigmine and glycopyrrolate, the patient is not waking up. So what happens is, the pseudocholinesterase levels in some people is low. Just like the INH in people who have low acetylcholine or something is there, metabolizer, they may have reactions to it. So pseudocholinesterase level is low, so succinylcholine is not broken down at the rate at which we want to break it down. So they will have prolonged apnea. So what you have to do, or prolonged paralysis, what you have to do is we have to provide them support for breathing until that everything is metabolized. Depolarizing one was this, non-depolarizing commonly used is rocuronium. It is reversed with sugammadex. Okay. Next is alcohol. Almost more than 50% of the, not more than 50%, I would say about 20 to 30% presentation in the emergency department is somewhere related to alcohol. Either they have drunk it or somebody else drunk and they brought that they were the drunk person were the reason for these people to appear in the emergency department. Yeah. Maximum limit in the UK is 14 units per week. Yes, 14 units per week. Whether it is male or female, there is no discrimination. The law is 14 units per week. Previously it was 21 units for males and 14 for females. Then females agitated and said, why this discrimination? Then they said, okay, we can't increase your to 21, so they said, okay, 14 for both. Okay. Driving limit, alcohol legal driving limit is 80 milligrams per 100 mils. Harmful drinking. Definition is asked in the exam sometimes. How would you define harmful drinking? How would you define hazardous drinking? Pattern of drinking that could lead to harm is harmful. What harm? Physical, mental, socio-economical, psychological. Hazardous drinking is pattern of drinking or alcohol consumption that can lead to harm. Isn't it? Hazardous is, it's an hazard. Pattern of alcohol consumption that can potentially lead to harm or place the patient at risk to harm. Problem drinkers. The problem drinkers are males who drink more than 14 units per week, and females, although legally they are allowed 14, but they are called problem drinkers if they drink more than 11 units per week. advice on alcohol. Just telling them that cut down the drinking may not work. You need to do a cognitive behavioral therapy. You can't do it in the emergency department, so you need to refer them to something called as Resolutions or Alcoholic Anonymous. Multidisciplinary approach is taken. You need to tell them, rather than telling them to avoid drinking, find out with whom they drink, how much they drink, what they drink, what time do they drink. If you understand their pattern, tell them to make a drinking diary. Whenever they go, where they go, with whom they go, what they drink, how much. How much will be, they might not even remember later on. Maybe next day when they see the bottle or something, they might say, oh, I drank too much, or they might quantify it. Then once you identify the pattern, those are the triggers. So you have to tell them, avoid going with this friend, avoid going out to this place, avoid doing this. So you identify the trigger and tell them to avoid those triggers. You can involve the family, it's called as family therapy. Drinking diary is something which helps, and resolution referral. The questions could be framed as, apart from telling them to cut down on their drinking, what could you tell them? To maintain a drinking diary, avoid the triggers, family therapy, multidisciplinary cognitive behavioral therapy, which should be continuous, and reference to Alcoholics Anonymous or Resolutions. There is something called as FRCEM technique, in which you give them feedback, you indicate that it's their responsibility, then you give them the specific advice, then they present a menu of options, you encourage self-efficacy and empathy. DKA, hot topic for the college, hot topic for you in the department as well. It can be the first presentation of a diabetic, so especially pediatric patients. Yes. What are the indications for doing a blood gas in a pediatric population?
Gait, low GCS,
Okay.
abdominal pain,
Yes.
tachycardia, tachypnea, MSS, whatever, and dehydration.
So whenever you're seeing a pediatric patient and any of these 5 is present as a symptom or presenting complaint, you need to do a venous blood gas. Anybody who comes with abdominal pain, why is this important? Because this can be just the presentation for DKA. Anybody who's coming with hyperventilation, you need to do a blood gas. Anybody who's coming with persistent nausea, vomiting, you need to do blood gas because they may be dehydrated. And GCS, when it's low, you need to do blood gas. Okay. How do you define DKA? Concentrate on how I define. You don't even have to look at the PowerPoint. Diabetic, keto, acidosis, diabetic. BM greater than 11 millimoles per liter or known diabetic. Keto. Ketones in urine 2+ or in blood more than or equal to 3 millimoles per liter. Acidosis. pH less than 7.3 or bicarbonate less than it's 18 millimoles per liter. It becomes very simple if you define it like that rather than memorizing. All 3 criteria have to be fulfilled to be diagnosed as diabetic ketoacidosis. Sometimes you may see a patient who's maintaining his pH, bicarbonates are normal. That patient is diabetic ketosis, not diabetic ketoacidosis. However, the treatment might remain the same, but your definition changes, right? So diabetic ketoacidosis, all 3 criteria have to be maintained. Treatment is fluids. Anybody with more than 5% dehydration, vomiting, drowsy kids, give them fluids. What's the dose of fluid for resuscitation in diabetic ketoacidosis?
It's only 20.
It is
20
10 mils.
per kg.
In resuscitation of pediatric patients, it is 20 mils per kg, but except DKA and trauma, it's 10 mils per kg. So you give a bolus of 10 mil per kg. If a second bolus is needed, always speak to a consultant, because too much of fluid in pediatric population may lead to cerebral edema. Okay. How do you calculate? That's your fluid requirement for 48 hours. Maintenance plus rehydration minus resuscitation. Okay. Normal maintenance is for the first 10 kgs it's 100 mils per kg per 24 hours. Next 10 kgs it's 50 mils per kg. So that 1.5 liters over 24 hours is there. And then after that it's 20 mils per kg for the next every kg. In this, some pearls are there. If the patient is on a pump, you stop the pump. If the patient is on long-term insulin, the long-acting ones, continue that after discussing with pediatric consultant. Okay. Important thing is DVT prophylaxis in these people. Their blood is hyperosmolar. Sodium will be low, and that is pseudo-hyponatremia. Okay. What is the formula for osmolality?
2 sodium plus
2 sodium plus
urea plus glucose.
glucose. So when glucose is high, sodium level go down. That's just transient in order to compensate for the osmolality. Okay. Okay. When would you start insulin in a DKA?
After fluid correction.
After your first bag of fluid in an adult, or after an hour of fluid correction. Okay. Early initiation of insulin is associated with onset of cerebral edema. It has been published in pediatric population especially. Scenario will say, DKA patient is there, you started insulin, you started correcting potassium, you started correcting dehydration. Suddenly the nurse calls you saying that the patient is becoming agitated or has low GCS. What is your one most likely diagnosis?
Cerebral edema.
Hypoglycemia.
He is right, you're wrong. Every time you think cerebral edema, but in the exam, the examiner is looking for hypoglycemia. Anybody whose GCS goes down, first thing you want to check is BM. Finger stick glucose. Anybody who's seizing, ABC, then finger stick glucose, not lorazepam. Yes? So, neurological symptoms, finger stick glucose. As I said, insulin dose is no boluses, 0.1 units per kg per hour. Potassium should be replaced as per serum potassium. Long-acting insulin continued, subcutaneous pump stopped, low molecular weight prophylaxis. All of us should do low molecular weight prophylaxis in the ED. It should start early. How much potassium to be given?
Based on potassium.
Based on potassium levels. If somebody, normal potassium levels is 3.5 to 5.5. Anybody with more than 5.5, I will check again, not start immediately potassium. Insulin started. Anybody between 3.5 to 5.5, I would start 20 millimoles of potassium from the side. Anybody less than that, first I will start potassium, then I will correct the potassium, bring it to 3.5, then I'll start insulin. Okay. If there is cerebral edema, you can treat it with two things. One is mannitol, 1 gram per kg, 20%, or you can give 3% hypertonic saline, or you can use 1.26% sodium bicarbonate. If somebody is developing cerebral edema, what you have to do is you replace the deficit, the one which we calculated here, the deficit, which is your rehydration over 72 hours. You replace the deficit over 72 hours and reduce the maintenance by half. Formula for fluid is maintenance plus rehydration minus resuscitation. It is calculated over 48 hours and then started. Okay? So if somebody is getting cerebral edema, you will what you calculated over 48 hours, you make it over 72 hours and then recalculate and reduce the maintenance by half. Okay. This slide is red in color.
Shade red.
And there is a reason behind it. The reason is we are going to talk about carbon monoxide. People in the UK, they live in cold weather most of the time. We see sun once or twice a year. Heaters are on, live in closed space, and they can come up with severe headache, vomiting, and when you take out the blood, there is cherry in there. That's your carbon monoxide. Clues are history. Clues are in history. Multiple family members affected. The headaches or symptoms happen only at a particular place. When I am at home, I get headache. When I go to work, I don't have headache. So I do more locums. So it can lead to ischemia and infarct of your heart, of your brain. That's why arrhythmias and seizures are two things which are still for hyperbaric oxygen. But in the UK now, hyperbaric oxygen is questionable. However, in the US curriculum, it's still there. Carbon monoxide is having 240 times affinity than oxygen to combine with hemoglobin. It shifts the curve to the right. The oxygen hemoglobin dissociation curve goes to the right. To the left. To the left. It shifts to the left. So this is the clue. And I think that is it about carbon monoxide. We will stop here and we will continue in the next slide.
Thank you.
Thank you.